There's no question we are incrementally encroaching on the surgeon's territory. And we've seen it now with the enteric bypass, and I think we're going to also see it with the gallbladder. But for now, the title of this presentation is Management of Acute Cholecystitis in Surgically Unfit Patients. And I want to emphasize surgically unfit patients because we must follow the standard of care. And currently, the standard of care for the management of acute cholecystitis is surgery. The Tokyo guidelines from 2018, which still apply in 2023, are that laparoscopic cholecystectomy should be performed within 7 days of admission. And these guidelines differentiate the urgency into 3 grades. So grade 3 would be a patient with organ or system dysfunction. That surgery should be done within 24 hours. Grade 2, white cell count greater than 18,000 and marked local inflammation, less than 48 hours. And grade 1, a patient with mild local inflammation, that patient can wait up to 7 days. Those are the guidelines, and we need to follow those guidelines until they change. So who is the surgically unfit patient? Well, that's the patient that the surgeon says, I don't want to do the surgery, or I want to delay the surgery. So that could be a patient with severe comorbidities, patient who's acutely ill, for example, with acute pancreatitis, which may be associated with gallstones, where further workup is needed, perhaps elevated liver enzymes. Patient needs an ERCP first. And there are sometimes practical issues. There's unavailable staff or an unavailable operating room. So the surgery must be delayed. So these patients then are referred for non-surgical gallbladder drainage. And historically, that's been the last some 50 years now, historically, that has been percutaneous external drainage. Oh, what just happened? I'm sorry. My apologies. I wanted to get rid of that little message and I apologize. Here we go. Percutaneous external drainage. And it has been the standard of care, and it has significant advantages. It's a bedside procedure. Not always done that way, but it could be done at the bedside under ultrasound guidance. And it can be done with local anesthesia, maybe light sedation at most. It has a near 100% success rate, and it has a negligible impact on future cholecystectomy. It may have some impact, but it's negligible. But there are drawbacks. Now I can't, here we go. There are contraindications. Coagulopathy, patient with ascites, an obese patient, or a patient with interposed bowel. There are skin issues, the discomfort of the percutaneous drain. It's unsightly, of course, and there is daily maintenance required. There are issues related to the drain itself. There can be leak, it can migrate, it can occlude, and there can be bleeding. That's in up to 20% of patients. And then after removal, studies have shown that recurrent cholecystitis occurs in 41% of patients. So up to half of the patients will have recurrent cholecystitis afterwards. And even though very rare, this is something no patient wants, a non-healing fistula. So the advantages of internal drainage address the drawbacks of external drainage. There's no skin discomfort. There's no maintenance issues. Cosmesis, a beautiful word. It's invisible. And there's no risk of an external fistula after removal. But what I think is the most important advantage is it preserves bile physiology. And a lot of the work we do as gastrointestinal endoscopists is preserving the body's physiology. So internal drainage can be done with two approaches. The first is transpapillary, and the second is transmural. Now, I'm very honored that Dr. Kozarek is here in the front row. And this was a paradigm shift to actually explore the cystic duct as a route to access the gallbladder. And he was the first one in 1984 who reported on transpapillary cystic duct cannulation. This was a new frontier, new territory. And he was able to successfully cannulate the cystic duct during ERCPs that he did at that time in 74% of the patients. And he concluded, and I'm quoting him, selective access to the gallbladder may ultimately expand the diagnostic and therapeutic horizons. Those are the words of a true visionary. In 1990, we now move to Greece, and Ferretis, who visited Nipsandra's unit and I got to know personally very well, reported on the first transpapillary nasal cholecystic catheter drainage of the gallbladder. This case report, 2 patients who had gallbladder empyema from impacted cystic duct stones. He placed the nasal cystic catheter. That catheter dislodged the stone from the cystic duct into the gallbladder, and the empyema resolved. And then in 1991, we go to Japan. So this is truly a global phenomena that we're seeing of the evolution of gallbladder drainage, transpapillary gallbladder stent drainage. And here in 14 patients with febrile cholecystitis refractory to antibiotics, they underwent placement of a 7 French gallbladder stent. Fever resolved in all of these patients, and pain improved in 2/3. And then subsequent to this, there have been many reports on gallbladder stenting, transpapillary, but this is noteworthy because it is a multi-center prospective study from Korea with a very high technical success rate, nearly 80%, using 7 French double pigtail stents, varying lengths. Mean procedure time, 22 minutes. 22 minutes. That's fast. Adverse pancreatitis, okay, that's inherent to ERCP. Cholestasis in 8.7%, but all of this resolved without the need for any intervention. The median patency, 2 years. That means that really the stent's acting as a wick. It's not draining through the stent. It's draining through the ducts alongside the stent. So you probably could have kept it in longer. So transpapillary drainage has the advantages that if the patient has a bile duct stone, and often the patient does, you can combine that procedure with stone removal. So that's really one-stop shopping. And if you don't perform a sphincterotomy, and you really don't need to with proper skill, then it's possible to do this in patients with coagulopathy. And there is no, and I'll underscore no impact on cholecystectomy. This is where the surgeon afterwards can't blame you and say mea culpa that I sent the patient to you for the ERCP. And of historical interest, makes me feel a little aged right now, but when I joined Nipsandra's unit in 1991, I was doing this almost daily, MTBE, methylturbutyl ether infusion through a nasal cystic catheter for gallstone dissolution. Now, it was phenomenal therapy, actually. The problem was the toxicity because it vaporized it at a very low temperature. Now, we actually, in the interim, have new ethers that vaporize at a much higher temperature and are virtually non-toxic, but they never had the chance to emerge as an option for patients, but perhaps they will as the crusade to save the gallbladder continues. The drawbacks are that if you do ERCP, yes, you may get pancreatitis. And there are multiple cannulation hurdles. So it starts obviously with the papilla, then the bile duct, but then you got to get in the cystic duct, and then you got those valves of Heiser, and you got to get in the gallbladder. And when you put your stent in, you can injure the cystic duct, and you may sometimes even perforate. And there is some relative bile duct obstruction by the stent in the gallbladder that can lead to cholecystitis and cholangitis. So those drawbacks of transpapillary make the possibility of internal drainage, but going transmural, attractive. And again, very honored, Todd Barron is here with us in the audience, and he is the first to report on this concept of EUS-guided gallbladder drainage. He did that together with Mark Tabazian. And at that time, Todd was the ERCPist and Mark was the endosonographer, and they teamed up together to do this procedure. 19 gauge FNA needle, then dilated with a 4-millimeter balloon and placed the stent. So this is using the Seldinger technique. This patient had undergone placement of a SEMS in the bile duct, who subsequently developed cholecystitis. Now, after that, many reports on EUS-guided gallbladder drainage using double pigtail stents followed, notably from Korea. These case series, however, despite very good technical and clinical success rates, did report significant complications. And those complications were related mainly to leak, bile leak and air leak. In other words, leak coming either from the gallbladder or from the bowel. And that's because we are intentionally perforating two non-adherent walls. We're creating a hole in two walls. So of course, there's a risk that it can leak from either end. The gallbladder, as you know, is not adherent to the bowel. There is on EUS this very bright echogenic layer between the gallbladder and the bowel wall. And at surgery, you'll actually see the stent between those two walls. So at least it inspired me to start thinking, is there a way that we can prevent that leakage from occurring? And the two tools that we needed were first a delivery system that eliminates over-the-wire exchange, the Seldinger technique. Radiologists can do a wonderful job. They're very close to their target using the Seldinger technique. We're far away and we lose too much time in between our exchanges. We need to be able to do it immediately. So the transluminal stent delivery system, electrocautery enhanced, eliminates over-the-wire exchange. We can access the target lumen with the stent-loaded catheter. So the catheter is sealing off that hole we've created the entire time. Then the stent that we place, because it's lumen-apposing, because it's fully covered, because it seals off that tract that we've created, that hole, the two holes, is preventing any leakage from occurring afterwards. But importantly, it also provides us with a port for transluminal intervention. And this is an underappreciated advantage of the LAMs, that we now have a port to access structures outside the GI tract. In a way, this is our notes enabling device. Could have called it that too. So we have seen reports on various trans-LAMs gallbladder interventions, which was all fantasy not too long ago, that we could actually endoscopically go in the gallbladder and we could remove the stones directly ourselves, or we could do mechanical lithotripsy, or we could do EHL and laser lithotripsy directly through a gastroscope. Or we could do biopsies. I've done that many times. And there have been reports of polypectomy, case reports. And I'm just waiting for the report of EMR and maybe next ESD, I'm sure it will come from Japan, in the gallbladder. So EUS-guided gallbladder drainage has the advantages that if you have a delivery system that guarantees that you can avoid leak, bile leak and air leak, bowel leak, using a device that is with a single device with a single puncture that is exchange-free and non-Seldinger. It's ultrasound guided. You can use fluoroscopy, but it's optional. And it enables translam stone clearance. And this is anecdotal, but can be durable. These are the advantages of this platform, but let's not forget the drawbacks that have been reported. We firstly have the same drawbacks that the radiologist has. Patients with coagulopathy, interposed ascites or vessels. In intervals distance greater than 1 centimeter, we do have saddles that are 1.5, so maybe we can expand that to 1.5 now. Or a gallbladder that's permanently contracted, so you can't distend it with water infusion. It is performed with deep or general anesthesia. I sometimes even insist on general, on protecting the airway because of aspiration risk from bile gushing out afterwards, and the unknown impact on future cholecystectomy. And that's a big one. We really need to know whether we burn any bridges to surgery later on, should the patient undergo surgery. Now, what about the data? There's a lot out there. Most of it is all retrospective, anecdotal, historical comparisons. I almost breeze over those papers these days. I wait for the multicenter randomized control trial, and we have it now. So this is a multicenter trial reported by Anthony Teal. It took the lead on this. This is a great study published in Gut in 2020. And the bottom line is that the procedure times and the success rates of EUS-guided versus percutaneous gallbladder drainage were equivalent. But EUS gallbladder drainage had significantly lower adverse events, need for reinterventions, and unplanned admissions. And you see it summarized here in the data. They looked at 30-day success rates, 1-year adverse events, significantly lower, very significantly. Reinterventions after 30 days, significant. Unplanned admissions, significant. And their conclusion was EUS-guided gallbladder drainage should be the procedure of choice, provided that the expertise is available. And it's about that availability of expertise that we have courses like this, so that that expertise can disseminate. There are many open questions that need to be answered before this can truly disseminate. What's the impact on future cholecystectomy? Should this be done transbulbar versus transantral? That might depend on whether a possible future cholecystectomy is planned. Plastic stent through the lambs, timing for stone clearance, timing for stent removal. These are all questions that we need to answer. I do want to emphasize the current indications for EUS-guided gallbladder drainage. High risk for external drainage, patient with obesity or ascites. So essentially, the radiologist declining and saying, I think it's too risky. Why don't you do it? High risk for surgery and requiring long-term drainage. So again, the radiologist would agree for long-term, it probably would be better to have internal drainage. Internalization of an external drain. Don't wait too long though, because the gallbladder contracts. And every once in a while, failed ERCP as an alternative to EUS-guided bile duct drainage. Always try bile duct drainage first, but if that should fail, then one can consider EUS-guided gallbladder drainage, assuming, of course, that the cystic duct communicates with the bile duct. Here's my personal algorithm that I'll end with. So first I ask myself, is there an indication for ERCP? Because if there is an indication for ERCP, I'm going to do one-stop shopping. And I'm going to remember Dick Kozarik's paper, who first described transpapillary drainage, and I'm going to do that. Now, if I fail, that's when I'll consider EUS-guided gallbladder drainage. Now, if there's no indication for ERCP, that MRCP is great, or my EUS shows no bile duct stones, fine. Then I'm going to ask, is the patient a candidate for surgery? Now, if the patient's not a candidate for surgery, then I'll ask myself, was it likely to be a short-term drain or a long-term drain? And if it's a long-term drain, I think the radiologist will be fine with my doing internal drainage. But if not, I'll invite the radiologist to do percutaneous drainage. Now, if the patient is a candidate for surgery, I'm not even going to think about draining that gallbladder internally. I'm going to send that patient to the radiologist because that is the standard of care in 2023. Thank you.